good afternoon. Thank you for joining me today. The reason I wanted to do this talk is because um, I get a lot of questions from my patients who have various different types of cancers. And I have noticed that there's often a common theme in those questions. Regardless of whether somebody has a sarcoma or a breast cancer or even a lymphoma, many of the questions and concerns that come up are surprisingly kind of the same questions. And so I thought, one of the most rewarding parts of being an oncologist is to educate my patients about, their disease so they can make an informed decision about their care. So along those lines, I thought it would be really good to talk about sort of the basics of what is cancer. So I'll go into that a little bit. And then I also wanted to talk about what are some common sort of misconceptions about cancer and common myths about cancer that are often out there in sort of the internet and popular media that I wanted to address as well. And then if we have time, we can kind of go into uh, you know uh, once we kind of know a little bit about what is cancer, sort of what are the treatment modalities that are used to treat cancer and why those treatment modalities are often effective in the treatment of cancer. So um, the way I want to start off with sort of talking about what cancer is I'm going to kind of talk about something that seems unrelated, which is we've all had skin cuts in our life, right? So pretty much anybody probably from the time since they were toddlers has either scraped their knee on something or gotten a paper cut on their finger and had a little bleeding, but after a few minutes saw that wound scab over, and then after a few days or a few weeks, that scabbed over wound has replaced itself with brand new skin. So if you think about it, that's a pretty remarkable thing that our body does. Is if our skin ever gets torn within a few weeks, maybe beside a very barely noticeable scar, most small skin tears can be kind of healed by our body very easily. Well, why can our body do that? The reason our body can do that is because whenever we um, injure our skin, millions of skin cells kind of die instantly. And that sends a signal to the rest of the skin cells around that open tear saying, hey, there's an open wound here. We need to fix this. So those skin cells start dividing, and eventually those skin cells that are still alive surrounding that wound through just dividing are able to heal and repair the injured skin. So this is happening, by the way, throughout our body day in and day out. So our cells organs are constantly repairing themselves, especially our GI organs, our liver, our skin. They're constantly having cell turnover. So this is a very normal process in our body that happens every day and is very critical for the functioning of our body so that we can all stay alive. Our cells have very sophisticated signaling mechanisms to kind of balance between dividing and not dividing. And to make this simple, I like to explain it by explaining it as like green lights and red lights, right? So our cells have signals within them. There are green lights and red lights, and actually even yellow lights that tell a cell when to divide, when to stop dividing, and in the case of a red light, even when to actually die off, because sometimes you need cells to die off when there are too many of them. What happens in cancer is that these signals have completely gone out of whack. So there are too many green lights in a cell, too few red lights that are telling it to stop growing or to die off, and too few yellow lights. And the reason this happens is because these green lights, yellow lights, and red lights are actually governed by the DNA of the cancer cell, of any cell. And so a normal cell will produce a balance between the green lights, yellow lights, and red lights. So a skin cell will have more yellow lights than green lights, or actually even red lights when there's no reason to repair a wound. Whereas when you get a skin cut on your hand, the skin cells surrounding that cut will the DNA there will start producing a lot of green signals because it wants those cells to grow and repair that wound. Well, in the case of cancer, the green lights are always turned on, the red lights are almost always turned off, and the yellow lights are also always turned off. So those cells are continuously getting a signal to keep growing and keep dividing. Now, by itself, that is actually not enough to cause cancer, believe it or not. Even if a cell has too many green lights and is dividing kind of uncontrollably, eventually that cell will kind of exhaust itself out and it will stop dividing because the DNA eventually kind of becomes too damaged to divide anymore. Eventually, that tumor will run out of blood supply because if a tumor gets too big, um, it needs more blood in order to continue to grow. It needs nutrition, just like our normal cells need nutrition. Tumor cells need nutrition and blood and oxygen to grow as well. So it will eventually run out of that blood supply and stop growing. So by itself, that is not enough to cause what we consider to be a malignant cancer or a malignant tumor. You need other things to happen within the cell, including the cell has to develop the ability to actually make its own blood supply. The cell has to develop the ability to actually repair its DNA sufficiently so it can continue to divide. The cell also has to have to develop the ability to eat away at the connective tissue of the body so it can spread to other organs. And so, as you can imagine, um, for that cell to develop those abilities, actually, there have to be genetic alterations within the cell that allow it to do that. And those genetic alterations are all random. So, given enough time, any cell in our body can turn into a cancer cell. But because the mutations that need to happen to to make the cell do all of those things, divide uncontrollably, have the ability to grow its own blood supply, have the ability to repair its DNA so it can doesn't exhaust itself while dividing, having the ability to invade other tissues, having those mutations in the right places in the DNA at the right time is a very rare event. And this is thankfully why most people don't develop cancer, especially in the early years of life. And cancer is, well, unfortunately, all too common, especially as we grow older. The reason it's more common in patients who are sort of on the older end of the age categories because those patients just have had more time to be exposed to their DNA's had more time to develop these random mutations, and it just the right sequence of those mutations will turn a normal cell into a cancer cell. So this is true for any type of cancer, whether it's a lymphoma or a breast cancer or a prostate cancer. Basically, you need to have what we call these hallmarks of cancer in order for for a normal cell to turn into a cancer cell. And so that is basically what a cancer cell is. It's uncontrolled cell growth, but it is also the ability of that cell to invade other organs, and it's also the ability of that cell of those cancer cells to divide without exhausting themselves. So I want to go into some common misconceptions about cancer. I'm gonna, and we can definitely talk about what is cancer more if anybody has any questions. But I want to address some common misconceptions about cancer and cancer care because I think I get these questions a lot, and I think the first misconception about cancer that I hear a lot, and I think it's because there's been a lot of press about this in the media over the last few years, is the idea that if you develop cancer, that you should not eat any sugar because sugar feeds cancer. Well, the actual sort of reality is that we know from evidence, there's no evidence that if you stop eating sugar, that it's going to actually shrink tumors or actually improve outcomes in patients who have already developed cancer. Does cancer feed off sugar? Yes, but every cell in our body essentially feeds off sugar, so we need sugar to live. So a cancer cell in that sense is no different from a normal cell, that it needs glucose, nutrients to live, just like our normal cells. But there's no evidence that depriving patients of those nutrients is going to somehow starve that cancer out. What is true, and I think what is important to know, is there is plenty of evidence that before anybody develops cancer, eating a healthy, well balanced diet that is low in processed food and low in refined sugars. So I'm not talking about like complex sugars like bread, or like multi-grain bread, or like, vegetables which have sugars in them. I'm talking about refined sugars, right? Like, table sugar. Um, those Eating too much of that can both directly and indirectly lead to an increased risk of certain cancers, because that can lead to obesity and inflammatory state, and those do increase the risk of cancer. But once somebody has developed cancer, it's kind of like the horse is out of the barn, and closing the door behind the horse is not really going to make a difference at that point. So definitely eating a healthy, well-balanced diet is important. But the reason I bring this up is once somebody has developed cancer, and once somebody has started treatment for their cancer, what we as oncologists are more concerned about is not so much uh, the idea that the cancer is getting too many nutrients, but we're more concerned about the idea that the patient is not getting enough nutrients. Because one thing we absolutely know for sure is that patients who are eating well, are eating healthy, tend to tolerate treatment better and tend to do better than patients who are not eating well and not eating healthy. So actually the focus really in patients who have cancer should not be so much on cutting out things from their diet, but adding in new healthy things into their diet. So, one thing we worry about a lot in cancer patients is loss of muscle mass, because they're not as active usually when they're on treatment, and so their muscles are not getting the workout and the exercise that it needs to retain muscle mass. And so we worry about patients getting enough protein in their diet and getting enough activity. So I always tell my patients to focus on eating a healthy, well-balanced diet and getting enough protein intake, and that can be different for different patients. We often refer our patients to our dietitians and nutritionists to help them with their sort of dietary plan, so they can get the adequate nutrition they need. But sometimes patients need a bowl of ice cream, and sometimes that's what they want to eat, and that's totally fine to do. So I think that uh, you know that's one thing I wanted to address, is that medical evidence so far suggests that eating like less sugar, or cutting out sugar from the diet after the development of cancer does not seem to help in treating the tumor or improving outcomes. The second kind of thing that I wouldn't really call this a myth, but I would call this a concern I get from family members, is is the idea that when and family members are coming, I always really like it, by the way, when family members come to a patient's visit and are involved in their care, because certainly whenever somebody has a diagnosis of cancer, they need all the support they can get. And one thing I often hear from patients and family members is this idea that the family members kind of want to do everything for the patient, especially when they're undergoing treatment. And I try to again encourage my patients to do as much as they can themselves while they're undergoing treatment, well, whether that's chemotherapy or radiation therapy, or even after surgery. Well, of course, sometimes patients will need help with things because they're getting side effects from treatment, or because they have symptoms from their cancer. If somebody can do something by themselves, they should try to do it by themselves. So, for example, sometimes family members are tempted to tell patients to relax and sit down and not do anything at home, and the family members will cook for them, and they'll clean for them, and they'll do everything for the patient while the patient's at home, so the patient doesn't have to do anything at home. Well, the issue with that is, again, as we kind of alluded to earlier, if somebody is just sitting around and not being very active, they're eventually going to get weak. Their muscles are eventually going to get weak. They're eventually going to start losing muscle mass, and that is going to limit to probably affect their ability to tolerate treatment, which can ultimately impact the outcome of their care. So I always say, if a patient can do something by themselves, if they're up for shoveling snow or cleaning their yard and they feel up to it, they should do it. They should listen to their body. Your body will tell you exactly when you shouldn't be doing something. But if you're feeling well enough to go mow the lawn, absolutely go do it, because that kind of exercise and activity will help maintain muscle mass, help maintain what we call your performance status. That really does predict how well somebody tolerates and does on treatment. The third thing I kind of wanted to talk about, because this is also a common concern I get it from patients, and it's a very understandable concern, is the idea that, once patients come and see me, by the way, as a medical oncologist, there's often already been diagnosed with cancer. So, they've already either seen a surgeon already who's done a biopsy, or their primary care doctor has referred them for a biopsy, and they've had a biopsy done of a tumor and it's come back as cancer, and then they come see me as a medical oncologist to talk about next steps in treatment. And one common concern or question I get, because it's often been a few weeks sometimes since their initial diagnosis, is this concern that they want to start treatment as soon as possible, because both the patients and family are understandably concerned that if we don't start treatment soon, that it's going to adversely impact the outcome of their care. And what I always like to remind folks is, getting the right treatment at the right time is better than getting the wrong treatment quickly, right? So we often, because cancer care is so complex, because cancer care has actually, for the good, become multidisciplinary, where we don't just make decisions in a silo. We make decisions in coordination with our surgical colleagues, our radiation colleagues, often even our genetics counselors who need to be involved sometimes in the care of some patients. Often we need the help of our palliative care colleagues, our GI colleagues, to really come up with the right plan for the patient. We often need additional sort of testing that can give us more information about the specific tumor type a patient has, so we can really tailor therapy for that patient. We often need additional imaging. So because we have all these tools at our disposal to really tailor treatment for that specific patient and specific individual and specific cancer, that testing can take a little bit of time. And of course, while that time is ticking, patients and family members often tend to get nervous about, hey, when am I going to start treatment? I really want to kind of get this thing over with. And it's easy for me to say, and of course much harder for a patient to go through, but waiting to get the testing done is so very important, because that testing really makes sure that we're giving patients the best possible treatment they can receive. We also have data, by the way, evidence, by the way, on this. So there have been studies done in certain cancers. For example, in breast cancers, we know that from the time of diagnosis of your breast cancer to the time you start some kind of treatment for it, whether that's surgery or chemotherapy, or some kind of hormonal therapy, as long as the treatment is started in 2 to 3 months after your diagnosis, you'll be fine. Now, obviously, we don't want to wait like 6 months after a diagnosis to start treatment, but I think that pretty much never happens, as somebody has to wait 6 months before they start treatment for their cancer. It usually takes a few weeks, maybe a month, maybe 2 months at the most. But one thing I always like to reassure patients is, as a oncology team, as a not if we think a patient needs treatment sooner rather than later, we move heaven and earth to make that happen. So I've often admitted patients to get them started on chemotherapy because I thought they needed to start treatment right away. And we could not necessarily wait to start treatment because because of their symptoms. But that is definitely the exception to the rule of getting the right testing done at the right time so we can come up with the right plan. And whether that sort of time it takes to do that can be, of course, nerve wracking, it is so very important to get things right at the start. Because if you don't get things right at the start, it's very hard to fix later on. So, those are kind of, I had a few other things I could talk about, but I've kind of been talking for the last 20 minutes or so, I feel like. So I want to stop here. And I want to see if anybody has any questions about anything I said, or if anybody has any questions in general.
Guys are welcome to unmute and ask questions or put them in the chat. Either is fine. I'm looking at the chat now. I don't see anything. One thing, Dr. Fruki, that came in from a request that came in from a participant that couldn't make it today was to discuss staging a little bit and what
Oh, yes.
staging means.
Yes. So staging is actually probably also one of the most common things we talk about during any visit I have with a patient initially. So so to explain staging, sort of very simply, most cancers, almost all cancers, are staged in some way. And what staging allows us to do basically is to say how far advanced is this cancer, and it helps us guide the treatment. It helps us determine what is the appropriate treatment for somebody's cancer. So cancer, almost all cancers are staged from 1 through 4. So stage 1, stage 2, stage 3, stage 4. It gets a little bit more complicated than that because some cancers have like substages like stage 1A, 1B, 2A, 2B, 3A, 3B, 3C, etc. And even stage 4 can sometimes have an A and a B. Um, but but I think what's important to understand is this: stage 4 cancer is considered to be the same thing as metastatic cancer. So we often you will see oncologists use metastatic cancer and stage 4 cancer interchangeably. They basically mean the same thing, which is that the cancer has spread well beyond where it started initially and has kind of spread to distant sites of the body. So for example, breast cancer that is spread to the bones would be considered stage 4. Lung cancer that is spread to the bones or the liver, or really any organ outside of the lungs, would be considered stage 4. Colon cancer that is spread to the liver or any other organ outside of the colon would be considered stage 4 because it has spread beyond its initial site to a distant organ. So now, so that is basically what we call metastatic disease. Um, Unfortunately, for 99% of cancers, it is considered to be not curable disease anymore. It is still considered to be very treatable. Depending on the type of cancer, the prognosis could still be excellent. But for some cancers, unfortunately, the prognosis is not so good for stage 4 breast cancer, for stage 4, sorry, any cancer. Um, but stage 4 basically means disease that has spread beyond where it started, to distant organs and is no longer curable for the most part. Stage 1 cancer is almost the opposite of that. So it is cancer that is still localized to the organ where it started. So stage 1 lung cancer, for example, is pretty much confined to the lung. Stage 1 colon cancer, for example, is pretty much confined to the colon. Stage 4 or stage 1 breast cancer is pretty much confined to the breast. It has not spread beyond the breast. It has not spread to other organs. And therefore is very treatable and very curable. And in the case of solid tumors, so non-hematologic, non-blood cancers, and like colon, breast, prostate cancers, lung cancers, the treatment often to cure the cancer is surgery. And then there may be a role for other treatments like chemotherapy or radiation therapy, depending on the exact specifics of the cancer. But surgery is usually the cornerstone of curative intent treatment. Stage 2 cancer is cancer that is still largely confined to the organ, but may be a little bit more advanced. So it may be a bigger tumor, for example, than a stage 1, or it may be a tumor that is spread to 1 or 2 lymph nodes, depending on the type of cancer. Stage 3 cancer is cancer that, again, is still not widely metastatic. It's not spread beyond to the extent of stage 4, but it is pretty advanced. It's involving the organ pretty significantly. By the time it's stage 3, it is almost in any cancer type spread to the surrounding lymph nodes. And so for this, we often need more than just surgery. We often need chemotherapy, radiation therapy, immunotherapy to treat the cancer. So it basically is the staging. So and every cancer has a different stage. So um, staging criteria. So you cannot compare a stage 4 breast cancers to a stage 4 pancreatic cancer. The prognosis and the outcomes and the treatment may be very different. The only similarity between a stage 4 breast cancer and a stage 4 pancreatic cancer is that both cancers have spread beyond the organ they started off with and have spread to other distant organs. But the actual treatment and the prognosis can vary widely depending on the type of cancer it is. So that is important to know. So staging helps us determine prognosis, and it helps us determine what would be the best treatment option, and then what is the goal of treatment. So we know, for example, for stage 1 through 3 cancers, the goal of treatment is pretty much always to try to cure the cancer. Um, Whereas for stage 4 cancers, except for a few exceptions, the goal is, we know that those cancers are largely not curable, so the goal is usually to preserve somebody's quality of life while giving them as much quantity of life as possible. And again, that can differ for depending on the type of cancer somebody has.
That was great. Thank you so much. And I just have one more question that came in advance, regarding remission and what it means to be in remission, what it takes to be given that
Yeah.
remission status.
Yeah, so that's a great question too. So, and that's actually a common word that is used in the cancer world is remission. So, remission is really kind of a technical medical term, even though we often use it kind of in the non-medical sense as well. That really only applies to blood cancers. We don't really use the word remission for patients who have non-blood cancers, so like breast, prostate, lung, colon cancers. But basically, in blood cancers, remission means that there is no evidence of cancer in the blood, no evidence of cancer in the bone marrow. The cancer seems to have essentially completely gone away. Now, remission is different from cure. Some people who are in remission are cured, but some people who are in remission eventually have a relapse of their blood cancer. So, and again, whether or not somebody in remission is cured or whether or not somebody in remission will have a relapse, it is highly variable. It depends on the type of cancer somebody has, and then there's different risk categories of that cancer. But in a general sense, remission means that there is no evidence of cancer based on the best tests we have available when we look at all the testing done for that patient for their blood cancer. In solid tumors, like breast cancers or colon cancers or prostate cancers, I don't like the word remission because, again, I think that it confuses things. It's not the right word for those type of cancers. What I like to say is, if somebody has been treated for their breast cancer, again, somebody can have stage 4 breast cancer, for example, and they can respond to treatment really well and you do a series of scans after they've started treatment, and the scans show that there's absolutely no evidence of any tumors left in their body, at least on the scans. Does that mean they're in remission? Well, again, um, we know that stage 4 breast cancer, for example, unfortunately is not curable. So what I say is, well, there's no evidence of disease at this point. And that's what I try to, the word I use in patients who have solid tumors is the word no evidence of disease. And I think that's kind of a similar thing as remission in blood cancers. Is that when somebody's responded to treatment so well that there's no evidence that there's any tumor left on their scans. There's no evidence of cancer in any of the testing we do. We call that somebody who has no evidence of disease. Now, whether that means they're cured will depend again on the type of cancer. So if somebody has stage 1, 2, or 3 breast cancer and they have no evidence of disease after treatment, they're probably cured. Whereas somebody with stage 4 breast cancer, for example, who has no evidence of disease after treatment, is probably not cured, uh, but it still is, of course, a great thing because it means the treatment is working, and we would likely continue with that treatment for as long as it's working. So it's a little bit confusing, but I tend to like the word no evidence of disease rather than remission in patients who have solid tumors like breast cancers or prostate cancers.